All right, guys. It's nice to see everyone here this afternoon for our Magic is in the Visit series of webinars, community webinars. Today we're discussing adaptogens. We're talking about burnout. Hopefully going to leave you with some great decision-making framework to go home with, to use with your patient population. So I'm excited for us to spend the next little bit of time together. If you're here, we're going to do the clinician sort of content right out of the gates. And we're going to talk about this decision making around choosing an adaptogen for your patients. And then we're going to move into a discussion around the Confident Clinician and how we can support you in your practice. So if that's okay with you, we're going to get started and combine both these great take-home insights for you today, but also leave you with some big curiosity and hopefully considering joining the Confident Clinician at the end of our call. We are saving our clinicians so much time and supporting them so much in their practice with content just like this every day. So I'm so excited for us to be able to talk through that together today. This is a really great conversation, this discussion around adaptogens. And it really brings up, sort of some big components and big pieces around how to make decisions with your patients, and also how you can best support patients who are struggling with stress and who are struggling with burnout. So without further ado, we will hop over to the multimedia that I have to share with you today. And hopefully I'd love for us to have a nice vibrant chat and discussion in the chat. So make sure that you don't be shy. I would love for you to drop in where you practice, where you're tuning in from. It helps us understand how to support you in thinking through decision making with your patient population. So here we go. All right, choosing the right adaptogen and our membership Q&A for the Confident Clinician. And hopefully you've got your questions ready because we will be answering all of them at the end of the session today. So if we haven't met yet, I am Dr. Jordan Robertson. So I am a naturopathic doctor. Although I would say that's becoming the least interesting thing on my resume. I am the founder of the Confident Clinician. So my background is actually in critical appraisal, the reading of research, the bringing research to practice. And as we all know, not every study belongs in your practice, and deciding which studies and which research is practice changing and which should be left to the side is really my area of interest and expertise. At this point, I have lectured to tens of thousands of clinicians, and my goal is really to help you develop a thinking framework for how you make decisions. We all want a rule book or a protocol to follow. And then when a patient comes into our office with a slightly different story or a slightly different comorbidity, it can feel challenging to make a decision in the moment for that particular person. And in integrative medicine, we haven't had great standards of care. We haven't had great guidelines to support us in clinical decision making. And that puts in a huge onus on you as the practitioner to actually go and dig into the literature and make those decisions yourself, right? And so my life mission is to raise integrative medicine to a standard of practice that we can all be proud of. I also want to get our clinicians, especially all of our female clinicians, out from hours and hours of unpaid labor, hours and hours of additional homework that comes with the job of being an integrative medicine practitioner or naturopathic doctor. So I am here to share with you all of those insights today, as well as to help you understand why I'm so interested in developing sort of this teaching framework for clinicians. We know that you are not a multiple choice writing robot when you're out in the real world in practice, although that's often how we treat you as a student. And we want you to actually develop the skills that it takes to be confident in your work, to be able to use a blueprint, or we call it our tactical blueprint on decision making in your patient population, and also master the evidence in a way that gives you the confidence and the clarity to communicate with your patients in a way that speaks authority and that also helps give them confidence in the work that you're doing with them. And that's really what I want you to leave with here today, is a little smidgen of that so that you can take it home and use it in your patients this afternoon or tomorrow morning. So when we talk about stress and burnout, we truly are coming into this conversation for the last 5% of the conversation. When we taught this as a Confident Clinician community and as a member, you will have access to all of this content. We discussed burnout in just about 4.5 hours of dialogue, going through the literature on it. And when we create content for you, the goal is that we help streamline your decision making. We help you feel like you're practicing with a consensus-based decisions, and also that you're doing what the other 1,000 clinicians are doing inside of our network. So this conversation on stress and burnout, if we're going to just talk about adaptogens, we're coming in, like I said, 95% of the way through the conversation. The differential diagnosis around burnout is insanely important. It is a workplace diagnosis. The diagnostic criteria needs to really be considered against many other causes of fatigue, like boredom, many other causes of mental health strain, like major depression. And there's a lot of research that finds it difficult to tease apart some of these other mental health diagnoses and the diagnosis of burnout, because they do show up either within the same patient or they mimic each other in different patients. And as a clinician, understanding how to implement the questionnaires, how to ask your patients about their work relationship, which we spent an entire session on, the motivational interviewing around workplace relationship with our clinicians, and then how to start to implement a strategic plan where we're ruling out other conditions that may mimic burnout, like anemia or hypothyroid or perimenopause. But we also are starting to empower our patient to make change within their own lives to support them towards improving their burnout. We also talked quite a bit about how burnout is a systems level challenge, right? And I always use the example that when we talk to our patients about burnout, it can feel like we're asking like a 4-year-old to turn off the lights in their bedroom for the environment when, like, you know, major industries are pumping pollution into the rest of the world. Treating your patient for burnout can feel like a drop in the bucket against some of the systemic challenges in their workplace that may be contributing to the way that they feel. Your role as a clinician is to champion your patient and to support them in making great decisions, in helping them develop workplace relationship, in helping them be able to access resources and tools within their workplace to help them understand their psychological safety at work so that they can actually be an advocate for themselves, but also to help them recognize maybe some of their traits that influence their susceptibility to burnout, like perfectionism. Okay, we discussed all of this inside our burnout module because as primary care clinicians, we really are responsible for catching a lot of this condition and helping be that touch point for people to start to make change in their life. And really, when we look at the breadth of evidence that supports burnout, things like positive psychology interventions, which include things like journaling and gratitude and some of those other tactics, the evidence for those things is actually stronger than the evidence for using adaptogens, which is what we are going to talk about today. So building psychological capital, building resiliency, exercise, allostatic load, right? These are the major conversations we should be having in the burnout discussion with patients. And then there's the nutrition and there's the adaptogens, which are kind of the cherry on top to what needs to be a big sustainable change and support with those patients from more of a psychological perspective. So I do want to preface the discussion on adaptogens, which love them, love the herbs. They should be a short-term solution. And we're going to talk about the limitations of the research on those adaptogens so that you understand where they fit in the context of helping your stressed patient They really are not the thing you should be reaching for first. And they're really not the thing that we should be discussing as part of a long-term strategy to support these patients. That it's about short-term symptom relief, short-term improvement of maybe some endurance, specifically physical endurance, and then using it in the context of all of the other strategies that we would use to support someone with burnout. So you can see on the slide there, I've got a screenshot from our at a glance section on burnout. And when we build a section and you're using that medical reference, it really is going through each section by assessment, by considerations, drug therapies, nutritional therapies, supplements, positive psychology interventions, etc., so that you in the moment can get the answers that you need to support you and your patient. So talking about the supplements, it's interesting because there are no supplements that have been specifically studied in randomized controlled trials for burnout specifically, okay? And burnout and feeling stressed are not the same thing. It really does a disservice to people who have struggled with burnout to imply that it's just stress or that we're treating acute stress, when really burnout is a very different phenomenon that is about that loss of psychological capital, that loss of resiliency that is happening across like many domains and across many days. Most of the research on adaptogens is in healthy, stressed individuals. Okay, so there is a huge differentiator there, that there is no literature on burnout, and the research on adaptogens is in otherwise healthy, for the most part, otherwise healthy, stressed individuals. So can we borrow that literature to help support our patients who are struggling with burnout? It's a great question. And it's one that we talk about often inside the Confident Clinician. What do we do when there is a limitation to the research that's available, but we're trying to create momentum in a patient where we can see similarities in our patient to the population that has been studied? We may find it perfectly acceptable to borrow literature from one area of medicine and apply it to another, but recognizing that we're being quite cognizant of that decision and we know the limitations of what we see. So if we have a patient with burnout and we give them rhodiola and they're not a heck of a lot better, we have to remind ourselves that actually this is not an intervention that has been studied in that population. Okay. And like I said, positive psychology, workplace organization, I love going through that stuff with patients, like helping them navigate and manage their work relationship. That stuff needs to be done first, maybe alongside a prescription for an adaptogen, but really an adaptogen cannot be the only thing that you do for patients who are struggling with burnout. The ones that I have focused on, and I'll show you why we focused on these and not others at the end of the presentation, is rhodiola, ashwagandha, and theanine. And so those are the ones that we're going to talk through what it looks like and how you would maybe make the decision between one or another. Okay, so choosing the right adaptogen. Interestingly, the outcomes that are studied in most of the papers are things like exercise tolerance, improved cognitive function, and reduced fatigue while at work. So we're not seeing like a cure for burnout and a cure for stress necessarily, but it increases capacity of that individual in the face of their current stress load. Okay, so that's what adaptogens do. They increase the resiliency of the patient in the face of the current stress load that they face in their lives. Okay, so neither of the adaptogens that we're discussing, rhodiola or ashwagandha, do we have awesome understanding of how they work. We have some ideas of how they work. We have some animal literature that suggests that when we do things like the stressed swim test with animals, that they can swim a little longer under the stressful conditions. We do think that rhodiola specifically improves a lot of markers of physical resiliency, so less muscle fatigue, less muscle soreness, faster recovery. Which is interesting because when we look at the literature on exercise and burnout, and we talked about this inside TCC, there's this neat intersection of like exercise actually helps patients quite a bit with burnout, but then we have the like barrier of motivation and the barrier of fatigue in actually getting our patient to comply to it, we talked about the potential practical application of rhodiola to help patients actually overcome some of those fatigue barriers for their exercise, because we do see some literature that would support that. So overall, the rhodiola literature, and this is really just a summary for us here, is that we see improvements in over 300 milligrams per day. So you do have to be a little mindful of some of the combination products, because the more we cram into a capsule, the less active ingredient you get. And if we've got like a little bit of rhodiola and a heck of a lot of other things, we may not get that therapeutic effect that we're going for. And most studies actually do BID or TID dosing. So the half-life of rhodiola is shorter than the half-life of ashwagandha. So you'll see when we get to that one actually can be taken once per day, whereas rhodiola probably needs to be taken twice per day in order for us to get that like therapeutic benefit that we're going for. Most studies don't see an improvement until the 2-week mark. There are a handful that see improvement at 7 days. And usually we're seeing improvement in fatigue in otherwise healthy but tired people, okay? I do have that bullet there around workplace stress. So we have studied rhodiola in like stressful occupations. Again, like I said, how do we know if we can borrow literature and use it in our patient population? Do physicians and cadets have higher rates of burnout than the average group of individuals? Maybe. We're generally testing it in students and physicians and athletes. So people that have high workplace demand, those are the people that are typically in these rhodiola trials. And so we may be able to extrapolate from some of that information that this may be helpful for supporting your patient who's on the verge of burnout or who is identifying with that like cognitive fatigue because of stress. So diving into some of the literature, and I showed you some of the specifics around this. So this is the one that, didn't show any benefit until the 14-day mark. It's the only paper that actually was testing them serially, like as of day 2. So they gave them the rhodiola, and then the following day they tested their cognitive function and stress and anxiety confusion, and they did not see a statistically significant difference until day 14. Okay, so your patients have to stick with it for about 2 weeks. The second one here was looking specifically at a female population. They did use burnout scoring for this, although being burned out was not a requisite for being in this particular study. But they did see some improvement in both their fatigue and also some of their cortisol testing throughout the day. We'll talk about the cortisol piece when we get to the ashwagandha. It's curious whether we care if it helped their cortisol, but that was notable in that particular paper. So the research, like I said, on exercise is interesting. It's really around, we think, perceived exertion. And I think that this actually has quite a potential role in our patients where we need them to exercise, but they have fatigue, they have low motivation, and we have that barrier for them to actually engage in movement. If you're interested in resiliency-based research, as I am, I'm just waiting for the exercise plus resiliency literature to explode. We're on the verge of understanding how that last rep, that last mile, when we really push our brain to adapt to exercise being one of the key factors that influences resiliency building. It's not there yet, but if you are watching that literature, the intersection here between like rhodiola, perceived exercise, and exercise as a therapy for burnout, I think is going to be a neat thread to follow over the next couple of years. So there's a review, the hung review there is not necessarily just in stressed individuals, but it's showing you that there is an increase in like physical capacity in general in the papers that are looking specifically at rhodiola. Okay. We do have some combination data. So in this particular one, they used 222 milligrams of rhodiola. So they had enough in there, I suppose, for them to see a positive effect. But you can see where we struggle with some of these combination products is there's really not enough of anything in that capsule in order for us to see an improvement. But for this particular combination, they did see an improvement in, those daily scores that they were tracking with respect to stress. Another one looking again at rhodiola plus a couple of other ingredients like green tea. And this one, they were specifically looking at brain function in patients who were mildly stressed after using the green tea and the rhodiola. So, I mean, we can probably argue that the green tea is having just as much of an influence on brain waves as the rhodiola is. But where I found this one is actually quite helpful is that often patients who especially who have that sort of high drive perfection type tendencies and they have burnout, right? Which those two things are interdependent. Often I find that treating patients with a capsule that is intended to help relax them sometimes can make patients feel concerned that they're going to lose all the parts of themselves that are high performing. And I don't know if that's ever happened to you in practice before, where you try and treat someone's anxiety and they're like, whoa, like there's parts of this I like because I'm such a high performer at work. I liked this paper because it actually showed that even the brain waves of patients who are taking rhodiola were not sedated by the supplement. They were relaxed but alert. And so you can be more confident in sharing with your patient that we don't expect a sedating effect from rhodiola or green tea, and that we're trying to take away the negative impacts of their high stress and still let them perform at a 5-star at work. This is a great paper, and I'm always curious about, drug-nutrient interactions and how we co-prescribe, right? Because patients don't land in our office on 0 medications or not seeing any other practitioners, right? Like that's quite rare, especially in my world. Most of our confident clinicians are working or want to be working as part of an integrated health model where people are working, collaboratively and happily with their family doctors or primary care practitioners. So we do have a clinical trial that combined rhodiola with sertraline. It was more effective, actually, if they were combined, but they actually proved safety with this as well. It's contrasted to a single case report. And one of the things I always want clinicians to be thoughtful of or think of is the weight of evidence of something that we're talking about. So we have a randomized control trial, and although it was small, we intentionally gave people rhodiola and their antidepressant at the same time. We saw no safety issues, and we saw improvement in the way that they felt at the end of the trial. We contrast that to a single case report of a 68-year-old person who had suspected serotonin syndrome when he combined his paroxetine and rhodiola. Okay, they use this, and the conclusion in the article is rhodiola is dangerous. Nobody should take rhodiola, right? So for you as a clinician, how are you going to manage this challenge? And actually, I'm quite curious in the chat, if your patient came to you on an antidepressant and rhodiola was the best indicated herb, based on these 2 bullet points, are we happy co-prescribing or not? Right? And this is one of the challenges we face in integrative medicine because the weight of evidence is small on both sides of that fence, right? We only have 1 clinical trial comparing them. We only have 1 case report. But when we start to talk about like a systematic way of thinking about decisions in practice, we can help you feel more confident navigating this particular challenge in your own work. Okay? All right, so let's contrast that. So first, like summarizing there, we've got rhodiola. It's got to be more than 300 milligrams, especially if it's in a combo, okay? It's going to be dosed BID, right, because of the short half-life. Our expectations around it is reduced fatigue in the face of workplace stress. We may see some improvement in like exercise or physical capacity. We don't see a ton of change in cognitive function. Okay, so that like brain fog feeling in some of the trials was not significant. We don't see this insane cognitive change in people who are taking rhodiola. It's mostly a decrease in workplace-related fatigue and a decrease in physical fatigue. Okay. Then we've got ashwagandha, okay? And this one, interestingly, has been studied much more in the context of changing cortisol levels. And we went through a massive discussion about whether or not testing cortisol is even warranted in people who have stress and burnout. And we came to the conclusion that the answer is no, given how much variability and habituation and how much adverse childhood events and time of day and when they have the blood draw done and how stressed they are driving to the lab. There are so many things that influence a plasma cortisol level, and we have nothing to compare it against because, and we reviewed this inside TCC, the inter-individual habituation to repeated stressors is going to be different in every patient, meaning if I pushed you up on the stage and I said, it's your turn to present, your cortisol might spike. And tomorrow, if I push you up on stage and I say, your turn to present, 20% of you, your cortisol will be higher. And you're like, oh my God, it's that presentation stress again. And 80% of you, your cortisol will be the same or lower because you habituate to repeated stressors. The problem is, and I digress, that we don't know who your patient is, and testing a single cortisol reading is really not giving us enough information to guide treatment, nor, and I'll show you a slide in a sec, nor is it giving us any information about whether or not our treatment is being effective. Okay? So ashwagandha, there is a dose-response relationship, and you will find studies that say that 125 milligrams is fine. I disagree. We don't start to hit the multiple markers that we're shooting for with ashwagandha until you get above 250 milligrams. Okay, and I'll show you a diagram of that. There are some studies on other forms and variations, tinctures, sustained release, etc. The benefit is in the dose. So there are some tincture studies that are quite confusing around how much is actually in the product, and they are generally unsuccessful. In the studies where the tincture has been shown to be dose matched against 250 milligrams, they are successful. My perhaps bias, but opinion is that I don't want to guess. And so if I need to pick between an unknown liquid version and a known tablet, I'm probably going to choose the tablet 100% of the time. Okay, but there is a dose response relationship, and you can find doses that are quite a lot higher than 250 milligrams. But again, I point out that minimum viable dose because it's important for when we look at things like combination products, which you may find on the shelf, or when we start to talk about trying to have the lowest effective dose so we don't cause any side effects, right? Like if 250 milligrams works, then why would we ever give 750 milligrams, right? We don't need to. And so I like you to understand that piece around what that lowest effective dose is so that you can start there and monitor your patient going forward. Okay. The most interesting sort of newer discussion with ashwagandha is around food-related cravings and binge eating that's associated with stress. There is a little bit of budding literature around whether or not ashwagandha actually helps people control their food-related behaviors in the face of stress. And I have a couple of those references for you here. So longer half-life, once a day, okay? We don't need to do BID dosing. You can see that there is a little bit of a dose-response relationship, and I have another slide that shows you we kind of hit all the buttons when we get above that 250 milligrams. When we talk about safety and we talk about concerns, right? And as soon as we say ashwagandha, people are like, but what about testosterone? But what about the thyroid? We have to remember that when we study these healthy groups of individuals, and there's actually so many papers on ashwagandha, that we don't give it for very long, and we don't give very much, okay? And we don't see a pathology come up from that application of ashwagandha. So if we take healthy women and we give them ashwagandha and we do it within the right dose and we do it for the right amount of time, nobody develops a thyroid issue, nobody has high testosterone. Okay? There are applications of ashwagandha in the world of fertility and in the world and in other worlds that start to seem to influence various lab markers in other populations. But when we use it in a healthy, otherwise well population, it is not pushing on those hormone pathways to the point where it causes pathology. You are not going to have abnormal hair growth in a female patient who takes the right dose of ashwagandha for 8 weeks for her stress. Okay. And I want that to be quite clear and easy for you to understand because your patients go home and Google what you have given them, or I think now they chat GPT. And what they get back is the whole wide world internet telling them all the terrible things about that herb. So many, many, many papers on safety, many, many papers on healthy individuals, and we see no pathological changes in hormone levels. Okay. One case report. one case report with hypocortisolism. Very curious whether or not this patient actually has Addison's. If you go back and read it, I have the reference for you there. Ashwagandha does lower cortisol, right? It does. That's part of probably how it's working on the HPA axis. In this particular case report, when we're talking safety, the person was taking ashwagandha, presented to the hospital. They had hypocortisolism. They had to leave the hospital on hydrocortisone, on treatment for Addison's disease. And they followed up with them 6 months later, and they still had it. And they had discontinued the ashwagandha when they presented to the ER. So not to be biased, but it is incredibly unlikely that a herb that has never shown this before induced a permanent state of hypocortisolism in the patient. Which is much more likely is that that patient was feeling unwell, took the ashwagandha as a consequence to that, and eventually landed herself in the ER and then was subsequently diagnosed with Addison's. Okay, sounds much more probable, but I did want to make you aware of that because they never improved after discontinuing the product. Okay, so cortisol, ashwagandha does lower cortisol. And like I said, it's awfully curious whether or not we care, but it's likely part of the mechanism of action for how it's working with respect to the HPA axis, right? We like cortisol. We want cortisol. There should be cortisol in your patient. What we don't want is sustained elevated levels of cortisol. The one little spike, because I pushed you up on stage, is not pathological. It's not causing a problem, right? That's not what we're treating. We're not treating a single spike. We're treating sustained elevations in cortisol. And so when cortisol is reduced by ashwagandha, that's likely part of the improvement, but I'll show you on another slide, 40% of patients, their cortisol doesn't change at all. So measuring it is not helpful. It's interesting to know that this is how it works, but it's not important for you to measure it, and it's not important for us to understand where their cortisol is at with respect to their treatment. Okay. Got some other papers here that show, okay, so same thing. So using things like the GAD-7 tests, we're looking at some of the perceived stress questionnaires. Some of these are not practical for you to do in your office, like the PSS is not a practical in-office test, but there are other measures of stress that are practical for you to do. You also can just ask your patient if they're stressed. That seems to be about as sensitive and specific as we need to. And we do see a reduction in stress. We see an improvement in quality of life. It takes a little longer for ashwagandha to work as it seems. So we talked about rhodiola, 14 days is where we start to see the statistical difference. With ashwagandha, it's taking slightly longer. So most of the studies are not seeing a change much before 30 days. And they're seeing improved quality of life. They're seeing improvement in anxiety and the feelings of stress. So it's a little bit different than the rhodiola. We are seeing a little bit of an improvement in sleep quality and sleep scores with ashwagandha, and we don't see that with rhodiola. Okay, I highlighted this one because it's that's a great number. 64% of people saw a reduction in salivary cortisol, but that means that 36% didn't, and that's still also a lot of people. And so we really can't use cortisol to understand measurement. So with this particular, so this was the anxiety scores and the stress scores. What they didn't do a good job of, and so I drew it in myself, is actually comparing the pre and post scores of the individual groups. They did achieve statistical significance from the beginning to the end of the trial. Their little diagram seemed to omit that particular detail. And so using it on day 30, they had achieved statistical significance. And then by day 60, it was even further. But in any of the papers that tried to check in a little earlier than that, so this is one that was looking in earlier. They actually tested an hour after giving the ashwagandha. We do think that it takes a little bit longer for some of those stress effects to actually work. In this particular paper, they did see improvement in mood within 1 hour, but that is not consistent across all of the studies. It's usually about 30 to 60 days for us to see some of those other sustained improvements. Okay. This is the one that was looking at the dose response. So remember I said at the beginning, anything over 250 milligrams, and I'm relatively happy with that. And if we're in the 125, then I'm not. So the way they actually presented this data is they made it sound like all the doses were effective. But when we get into the actual details of it, then we can see that the 100, this is a very tiny diagram, but the 125 milligram didn't achieve improvement in every single category. So the sleep, like some of the other pieces that they were measuring, it was not a spectacular effect with 125 milligrams. So if you leave with anything today, it's that your minimum dose for ashwagandha should be 250 milligrams. And I did say that this is like, in my opinion, even though the paper itself said that 125 was fine. Okay, this was another one looking specifically at sleep. So hopefully I'm helping you build sort of like this comparison across, and I'll show you the comparison of the two herbs when we're complete here. But they do have slightly different indications, right? There certainly is the like compliance component of a BID rhodiola and a once a day ashwagandha, but the ashwagandha does improve sleep. It improves food cravings. It seems to have a different effect on anxiety. Whereas when we're talking rhodiola, we're mostly talking about fatigue, right? Fatigue related to actually testing like their workplace resiliency and fatigue and their physical fatigue. Okay, so there is that slight difference between them. This is one looking at food cravings and sleep. And of course, the worse they slept, the worse their food cravings were. But they did see an improvement when they used the ashwagandha. This is the one that's the most robust, looking specifically at uncontrolled and emotional eating. And by week 8, they saw improvement with the ashwagandha. And this, I think, is a really interesting conversation, especially as we start to embark on bigger discussions around appetite regulation, obesity medicine, things like the GLP and GIP medications, is that we are more curious than we've ever been about the emotional influence on appetite. And I was pleasantly surprised to see the literature that links ashwagandha with food intake as well. And so interestingly, like they did have a decrease in body weight, even though that's not what their primary outcome was looking at. But they did see that in this particular study. They used a relatively high dose of ashwagandha in this study, 300 milligrams twice per day for 8 weeks. But I just thought that was kind of an interesting one. You can see that there's a lot of data on all of these. Hey, I'm going to skip this slide. And we're going to talk about theanine. So lastly, theanine, and really where the benefit for theanine comes in is in its immediacy, okay? It crosses the blood-brain barrier and levels are elevated for up to 5 hours after administration. So the effect for it is it's really the most rapidly acting nutrient we have looking at stress. And there are trials that are specifically looking at it in like acute stress situations. It has a very short half-life, shorter than rhodiola, and so the multiple daily dosing. But really, if people are starting to take like 600 or 800 milligrams of theanine every day, like 200 milligrams every couple of hours, we're probably missing the point, right? It's really not intended to be taken as a chronic acute support for stress, but it is the thing that we have that has the most rapid action. So we've got some neat studies that look at using it with anxiety, sleep, and stress, cognitive function, markers of stress during the day, and they are all improved with taking theanine. And like I said, there are those combination trials that actually use it in combination with rhodiola and see that sort of quiet alert or calm alert effect on MRI. And so that's kind of the effect that we're looking at or looking for in people who are taking theanine. Of course, right? I'm always curious about whether or not we could achieve that through food. And this UNO person, they have dedicated their whole life to studying the ratio of theanine to caffeine in various species of green tea and whether or not we can use that with a therapeutic effect. I did give you the couple of forms of green tea that actually have been shown to have that right ratio. Now, I would say in my general patient population, if I'm treating acute stress, I don't know if I'm having them reach for a tea or if we're going to use a chewable theanine, but I did want to put it in there, especially when we're starting to talk about, is there the potential for food-related interventions? There is some support for using green tea specifically to get the theanine effect from it. So you can see that we've got some comparisons to do, right? So there are these slight differences between those herbs and slight differences in which you might choose one over the other. And so when you're leaving the session today, what I want you to think about is like, what is my primary symptom or primary target? What's my patient's like primary obstacle? So one of the challenges we have in burnout is the safety of continued employment and how important that is for people to be able to maintain their work output while they work on themselves, for them to be able to stay well enough to stay at work. We had a big conversation inside the TCC module on this around how to help patients operate at a more mediocre pace inside their work, how to leverage work-related resources that maybe they haven't before, and so that we can stay in work, right? Because as I'm sure we've all experienced, the 2-week stress leave and then return to work, with a pedal to the metal doesn't actually solve anyone's burnout or work-related stress problems. And so we want to increase capacity in our patient while they remain employed as much as possible, right? So when you're thinking ashwagandha or rhodiola or with a sprinkle of theanine in there for acute stressors, it's really about how do I unlock potential in my patient so that they can do the other things I need them to do in order to create more wellness, more resiliency, and more capacity. So for some people, their workplace fatigue is going to destroy them. We want to increase that fatigue. We want to not increase the fatigue. We want to improve their fatigue. We want to increase their physical capacity at work. You're looking at rhodiola, right? Like that's where that benefit is. If we're on the other side and we have more anxiety related changes with respect to stress, if there is a sleep component, if the person has more emotional eating, right? We may be looking at ashwagandha as your better adaptogen in that setting, right? So if the person's mental health is becoming more of the obstacle versus their fatigue or their sleep is a barrier for them to actually recover, then we may be looking at ashwagandha versus looking at rhodiola, which doesn't have a lot of sleep data actually. And so that's how you're going to think about or make that decision. And then someone is going to say, well, can you just do both? And in theory, you absolutely could give both. But what I want for you to think about or think through with this sort of decision-making framework is knowing that you're doing it purposefully. So I'm choosing this because. I also think it's incredibly important that you understand how long it takes to expect an outcome. So rhodiola, I said at least 14 days. Okay, most studies were actually 28. With ashwagandha, aside from that one paper that said that people were less moody after 1 hour, most of the studies don't see improvement until 30 days, okay? And that's for sleep, that's for anxiety, that's for all of those indications that we were looking for. So when you prescribe for your patient, one, you want to set that expectation for them that this is when we expect to see change. You also want them to see this tool as something that is unlocking potential for themselves, right? So it's not, we're going to take rhodiola because you have a stressful job, because that creates this tie that the rhodiola solves the problem. It doesn't. It creates capacity while we work on the problem. So I showed you this example, and one of the things, and we've built this as one of our frameworks inside Confident Clinician, is I want you to be able to listen to dialogue or read dialogue that we're having about clinical decision making so that you can feel good about the way that you support your patients. And so I asked it, can you compare? Like, when would you use rhodiola versus when would you use ashwagandha? And it listens, right? Our smart search listens to all of our content. So hundreds and hundreds and hundreds of hours. It reads thousands and thousands and thousands of slides to give you a concise answer based on what we have presented inside of our community. And so it talks about, looking at shift workers and students, what the doses are, what to expect in terms of improvement, how to think through the decision, why you might choose one or the other. And then as sort of a bonus, the Confident Clinician search actually allows you to turn all of your searches into marketing materials for your practice, which I just wanted to show you as a total sidebar. So what about the others, right? So what about the others? You know what? There are not very many clinical trials on any other adaptogens. I put the theanine in there. There's a couple on holy basil. There is a couple on phosphatidylserine, and I always hoped that there'd be more, but really it pales in comparison to the weight of evidence we have for rhodiola and ashwagandha. You really don't have a good reason to choose one of the others unless it's like someone's grandma's favorite herb and they want to make a personal decision for why they choose something else, Schisandra or one of those other adaptogens. If they feel emotionally connected to that decision, great. But you as a clinician, the weight of evidence that's sitting with you, really rhodiola and ashwagandha are your first two choices. Like I said, you got to be really clear about dosing when we look at combinations. I have said absolute no-go on licorice for any circumstances at this point. The safety data is really clear that this is not the right choice for our patients. And like I said, really no evidence for needing to stray from either of those two adaptogens. I threw this in just as a sidebar. I did want to talk about cortisol and coffee just as a break before we jump into our Q&A. And I'm sure, like all of us, right, are like these perpetually myth busting online when it comes to hormones, when it comes to natural products, and trying to help people sift through all of the noise that they see on a regular basis. And so who has heard that cortisol is like that coffee or caffeine in the morning raises your cortisol, right? Like I'm sure that now it will be in your Instagram feed momentarily. This is the best study that we have on the impact of caffeine on cortisol. And what it shows is if you have never had caffeine ever in your life, and we give you 750 milligrams, all at once, it will raise your cortisol. And that's what that top line is there, is like as soon as they gave them 750 mgs, their cortisol was spiked, right? And their body, it was the equivalent of like being pushed up on stage and having to give a huge presentation. In patients who habitually drink 300 and 600 milligrams of caffeine, there was no impact to their cortisol. So when we talk about the impact of food or stressors or exercise or nutrition on cortisol, we have to be quite careful about what we're actually saying. So caffeine does not influence cortisol if you're a habitual coffee drinker. If you've never had it, don't have a cup of coffee before you go get your cortisol tested. But it really is a good reminder that we can't make a lot of clinical decisions based on one reading of cortisol or what we see in lab work with respect to stress. If your patient says they're stressed, it doesn't matter what their cortisol is, right? They're stressed. We don't need validation from their cortisol in order for us to treat them, nor should we track their cortisol in order to know if we're being successful. All we need to know is that they're less stressed, right? That they're getting better. So I wanted to share this just as a one-off because it was something that we talked about inside the community, and I was really curious about this when we started to look at the impact of nutrition on cortisol, and this is where we landed with it, that if you are a regular coffee drinker, you're good to go. If you never have coffee, just know that your one day that you have coffee is going to probably spike your cortisol, but that's not a pathology, right? That's not consequential at this point. So hopefully that gives you a window into what it looks like for clinical decision-making around burnout. But again, if we back up and we start to think on a bigger scale, if you're going to work with patients who have burnout, we really have another problem. And that problem is that you kind of have to be good at everything, right? So the impact of stress and burnout on female reproductive system, the impact of stress and burnout on other comorbid mental health, the differential diagnosis of stress and burnout with all the other endocrine disorders that we discussed earlier, the comorbidity with sleep apnea or needing to be a good diagnostician with respect to their fatigue is incredibly important. And this has always been one of our challenges when we look at when we look at being supported as a clinician in integrative medicine, is that we don't have anywhere that has a toolkit for us to be able to be good at everything and practice at the level that we all desire, which is why we created the Confident Clinician, because it allows you to practice at this level, right? Like at the level and the depth that we just went into 2 interventions, really, 3 if we count theanine. It lets us practice at that level for everything we do. Like, how would you feel if you saw a patient with burnout and you felt this good about prescribing their adaptogen, and your next patient had asthma and you felt this good about prescribing their intervention? That's the level that I want us all to be able to practice at. And so when we launched the Confident Clinician 4 years ago, our intent was that we could raise that standard for all of us, and that we also could save you time, because the amount of literature that needed to be read to create those 19 slides is something that none of you have time for. And these are just some of our amazing community members sharing how great it's been for their practice, and how much busier they are and how much happier they are in their work, having access to TCC at their fingertips every day, right? Like, what would it feel like for you if you had that level of support when every time you had a question about, like, well, do I do this or do I do this? Or what's the best choice? Or of these 2, what's the dose, right? If you had that level of support every time you saw a patient, what would be possible for you? And so when we created our framework of support, it's built off of these pillars that I want you to have the confidence in prescribing, the confidence in the language. I want you to feel like you have a blueprint to work from. And a blueprint is different than a rule book. And we often have this conversation about, is it a standard of care, or is it the intersection of personalized medicine and a tactical blueprint that shows you what the best evidence in this moment actually is? And that's really what we're after. Is personalized medicine is the way that we want medicine to be delivered. It's patient-centric, right? It actually helps them make the right decision for them. But that's not possible if the clinician lacks the resources they need to know what the options are, right? Or the clinician actually hasn't had the resources to be able to know how to discuss the different options that are available. Okay, so when we look at what the problems that our clinicians are facing, right? Clinician time and patient resources, probably number 1. If I took away all your paperwork and all your patient, research that you had to do in between, if I helped you finish your charts inside the visit, which is possible, right? What would that be like for you? What would be available to you if that was true in your work, that you closed the chart when it was done, that you never had to take work home? So we've built our at a glance section and our smart search so that you can save time in your research by accessing and leveraging our knowledge in the moment. So the at a glance sections is built just like the one I showed you earlier for burnout, where it's sharing, the information you need. It's hyperlinking to other areas of the site to help you with differential diagnosis. It's giving you lists of labs. It's giving you lists of treatment options. It's giving you downloadable handouts that you can use right in your patient chart. It's giving you everything you need to practice at the level that you desire with one click. The Smart Search actually listens to all the dialogue that we have inside TCC. So this explanation of rhodiola versus ashwagandha has made it into our search so that you can actually chat with our experts, with the people that have built our content, so that you know that you're getting the right information and that you can actually support your patient in the moment. So we used this example earlier, but how would I decide between ashwagandha and rhodiola? If that was something that you didn't want to memorize, you don't need to, because you now have that information right at your fingertips. The other challenge that we have, though, is that most research and guidelines actually don't talk about how. They don't talk about when to say what, or what the time constraints are in your office, or how to navigate it if the treatment is costly or requires the patient to actually do stuff, right? That the how is really missing in most research, which is why we have built our solution the way we have, right? It's dialogue based. Our knowledge base is built off talking, right? It's built off sharing. And so every time we present, we do it live the first time. Okay, so every topic has 3 to 5 hours of video. And when you're ready for that level of mastery, you can dive in and actually achieve that. But that also is what informs that smart search, right? So here's a question about like, what's the evidence for POTS or exercise in POTS? And that's pulling from an hour-and-a-half lecture on exercise in POTS and how to deliver this to your patient who feels like they can't exercise, right? And how to support them. So the how is really embedded in everything we do. So it's not a list of study summaries, right? It's the study summaries, but it is interpreted and captured in a way that actually helps you make decisions in your work every day. And then, of course, we have the loneliness problem, right? And I always find it so ironic when I teach on burnout, because this is like, we are the people who have burnout, right? Healthcare professionals have burnout. And we know that when we access advanced training and when we access mentorship, we can reduce burnout for healthcare practitioners. I think Confident Clinician is the treatment for burnout in integrative medicine because there's no one to talk to. But everything we do is live, right? And whether you can make the call or not and sit in and listen in the moment, everything is built off community and built off live dialogue so that you can actually ask your questions. And so if people come to a live lecture, they can ask their questions to the expert who's delivering it. If you want to go to office hours, you can sit in and ask your questions and get support in the moment that you need it. And so everything is built with that in mind so that you actually feel like you're part of a movement and part of a community, right? Those doctors who have said yes, they are the best and practicing at the absolute highest standard in North America right now, and you get to belong to that community as a member. All right. I always say we have a bonus problem being an integrative doctor. And the bonus problem is that you are also a business owner, which I don't know if any of us signed up for or if any of us wanted. But our bonus feature inside TCC is we know that you need that 360 support. And if we're going to do that level of research for you and the level of support for clinical decision making, you might as well be able to leverage it to actually grow your practice and be busier. So we've created access to instant marketing materials and also in-depth business workshops. So when you're ready to raise your rates, when you're ready to negotiate your lease, when you're ready to train your first staff person, that you actually have the resources you need inside of our community in order to be able to do that. We're excited about our next big business workshop in the summer is going to be on charting because everyone's dying for a charting workshop. Like I said, the Smart Search will turn every question you ask into patient-facing captions and patient-facing marketing materials. And so you can actually leverage our work, your search, and actually grow your practice while you do it. And again, we have that 360 support where you can actually get the information you need about how to grow your business inside Confident Clinician because we know that you need that. So this tactical blueprint, and hopefully you've felt a taste of that so far today, really solves that big problem, is that if you're going to practice in integrative medicine, you need to be good at everything, and there are no resources to support you until now. And so it allows you to be confident in your decision-making. It allows you to implement things right away. It gives you the blueprint, again, not a rule book, a blueprint of how to make decisions with your patient and the confidence to navigate how to make decisions with different patients who present with the same concerns, right? We give you the research that you need to feel great about the decisions you make, because how awesome are you going to feel tomorrow when you say, it takes 14 days for rhodiola to work, right? That alone actually empowers your patient to continue to work with you because you have the level of confidence to say that. And we also have built this consensus-based care model where if 1,000 doctors are doing the same thing as you, how does that feel, right? When you're in practice every day. All right, so how you can join. So we're going to throw the link in the chat for how to join the Confident Clinician. And when you join us, you are with us for a year, okay? And that gives you access to a year of interactive learning, all of the new modules that are coming out, but it also gives you access to our entire knowledge base the moment you join. So you don't get it dripped to you module by module. You unlock the entire knowledge base on day one, take it to work tomorrow, right? That's how I want you to feel about it. You get access to the Smart Search bar that integrates 100% of our content, as well as some additional advanced training courses that take a deeper dive, even than some of these medical modules that we have discussed today. So that's how you join. That premium membership is $13.97 for the year. Okay, and again, that gives you access to the entire dashboard. It gives you access to all of the medical modules, the AI-based smart search, the instant marketing materials, the community, the business support, right? The community forum, all of the things are literally unlocked the moment that you join and can change the way that you feel about going to work starting tomorrow. Great questions in the chat. So someone asked, I'm not tech savvy, which I'm here for you. I get it. And really, when we built this, our whole purpose and approach is, how do we save you time? Every decision we make, how do we save you time? How do we make you better? Right? And we have achieved that. We also, every time we think about where to put a button, where to put some information, what can we give you? It's all about how do we satisfy those two things, save you time and make you better in practice at the same time. So the platform is very easy to use. We have great tutorial videos. You do not need to be tech savvy in order to use it. And chatting with our smart search is great. It would give you some feedback and prompts as well. I've asked it questions and it's even said, that's not the question to ask, Jordan. What you really need to ask is, it's a great way to dialogue with our content and it helps support you even if you are not a tech savvy person. So you definitely can feel peaceful in joining. You don't need to have a big tech background in order to benefit from it. And it's another good question that someone sent me privately here is, how much time does it take for me to see the benefit? And I get that when, I understand, right? When I was in practice, I had a groove, right? I did the same things all the time. And some of our current doctors who work with us felt that way too, that they were like, this is going to disrupt my flow and I'm not even sure I'm going to be able to integrate it. But what we've found is that if people commit to keeping the tab open on their computer while they have their EMR up, that they become super users very quickly. And instead of saying, where can I find this? Maybe it's on PubMed. Where can I find this? Oh, maybe it's in that slide deck from the presentation I went to 2 years ago. Or where can I find this? Maybe I could post it in a Facebook group. Is that they know where the resource is, right? And they're turning to it as a resource in the moment all the time. So even if you've been out of practice for 20 years, or if you just walked out the door of school yesterday, right? Creating the habit of having TCC open on your dashboard allows you to become a super user quite quickly, even if you are, set in your ways and you have not made a change in your practice in a long time. And that's always a question I will ask people when I'm talking to them and say, like, when was the last time you made a big investment in your practice and what did it do for you? Right? And quite often people are like, well, when I hired a receptionist, this is what happens. Or when I switched to EMR, this is what happened. When I went to online booking, this is what happened. This is one of those pivotal moments in your practice, like any of those other investments that you've made that unlocked potential in you, right? It unlocked potential in you because now you have more time, you have more capacity, you can see more patients, you can seamlessly post on social media, right? Which is everybody's deep pipe dream. You unlock potential by having access to resources that elevate you. And this is exactly what we do. Okay, I'm just gonna shift through the chat here and ask questions. So someone said, one of the blocks I have when thinking about signing up for TCC is I wonder if I'll be faced with the evidence that most of the tools that we use are not evidence-based, and that most of the evidence is in the tools that other providers use. Okay, that is a really great question. Yeah, let's talk about that, right? And I think so let's just take a step back for 1 second. We're lifelong learners, right? Like we didn't go into healthcare to say, okay, tell me what to do and I'm never going to learn another thing, right? Of course you didn't, right? You actually partly were attracted to the practice of medicine in any dimension, the practice of medicine because you love lifelong learning. One of the challenges we're faced with every day in science is that sometimes we learn we were wrong, or sometimes we learn that something was like half true, and now we have a different way of looking at it. Or sometimes we learn that something that we weren't sure worked is the best thing that's ever happened to us. And that excitement and optimism around all of those possibilities, we need to hang on to. And I think if we have a worry that we're going to be told that something that we do doesn't work, or that we're worried that something we were taught is wrong, The consequence of never learning it or never unlearning it is so detrimental to your practice and to your patient. Whereas instead, if we can approach these discussions around evidence as being opportunities, right? Medicine is not getting more reductionistic. It's not. It's getting more holistic. It's getting more interested in behavior change. It's getting more interested in transdiagnostic medicine, which I have an article coming out about this soon, that actually integrative medicine is about transdiagnostic medicine, where your patient with PCOS needs to be evaluated for sleep apnea and heart disease, and you know that. That's the beauty of integrative medicine, not whether you use rhodiola or an antidepressant, right? That's not the magic. The magic is actually that you have time, that you have interest, that you're a behavior change specialist. The actual tools we use, we might learn that something sucks and we can stop using that, and that's great, right? And we're going to learn something new next week that works amazing, and we're going to use that for a while. But this idea that we don't want to learn if the things that we were taught were wrong, if that's a barrier, I think that's a problem, right? Where it actually should just be an opportunity to get better, right? And to learn something new. We certainly hope that medical doctors don't stick to their guns that they learned, in the 1960s. I would love for us to do the same and for us to approach conversations around change and new things and evidence as excited as we do about learning that a herb has a new indication. I'd like to be as excited to learn that it has less indications sometimes. So hopefully that answers it. And what we've tried to curate, and I think we've done very successfully at TCC, is that we've curated a culture of mind changing where we celebrate it a lot. I used to do this and now I do this. I used to have no idea that treating sleep apnea improved diabetic retinopathy, and now I do, and look at how great that is, right? The learning is amazing and the changing is amazing, and changing our mind is even more amazing. So I invite that, and we invite those hard discussions and those challenges into our community so that we can have those discussions and we can just continue to work towards getting better and better all the time, because that's what I want for us, right? It's just better and better all the time. All right. Thank you for staying with me 7 minutes past the hour. I hope that was helpful for you and that you have some tactical things you can take home and plug into practice tomorrow. Would love to see you inside the Confident Clinician. Have an awesome rest of your evening.